Welcome everyone. So the topic is postpartum hemorrhage. As word indicates, postpartum hemorrhage means bleeding occurs after delivery of the baby. That condition is known as postpartum hemorrhage. Now, postpartum hemorrhage refers to excess blood loss after delivery, and there are three types of postpartum hemorrhage: early postpartum hemorrhage, secondary late postpartum hemorrhage, and massive obstetric hemorrhage. Early postpartum hemorrhage is a condition in which there is excess blood loss greater than 500 milliliter in first 24 hours of delivery. Secondly, late postpartum hemorrhage occurs lasts between 24 to 6 weeks after delivery, and the massive obstetric hemorrhage is the blood loss greater than 2.5 liter, requiring transfusion greater than 5 units of the blood. That is known as massive obstetric hemorrhage. Now, the causes or risk factors are the uterine atony is the most common cause. Uterus become atonic and that creates postpartum hemorrhage. Macrosmia, fetal macrosmia, those babies who are large, relatively more than 4 kilogram, they may develop postpartum hemorrhage. Obstetric prolonged or labor, oxytocin use, induction of labor can also create this condition. Now, the retained products of conception, placenta previa, placenta accreta, genital tract infection, coagulation disorder, multiple period C-section can also give rise to this condition. And uterine inversion and rupture is also included in postpartum hemorrhage. Now, the signs and symptoms for the postpartum hemorrhage are anxiety, thirst, cold, dizziness, unresponsive. Patient will be unresponsive because of blood loss, and the tachycardia will be there in order to compensation the loss of the blood. So that's why increased blood and increased heartbeat will be there. Reduced urine output, that is a sign of shock. Tachycardia will be there. Hypotension and reduced pulse will be there. So these are the signs of a hemorrhagic shock because of blood loss. Management of the postpartum hemorrhage will be, first of all, the patient has developed shock, so primary survey should be initiated, and it includes airway, breath, circulation, and drug therapy. So ABCDE maintained: stop uterine bleeding by uterine massage, by manual compression, remove any clot in the uterus and vagina. Uterotonic agents should be given like oxytocin, rectal misoprostol, and centrometrine, repeat ergotamine, and carbaprost should be given. So these drugs can also help in postpartum hemorrhage prevention. And in case of the persistent bleeding, look for the genital tract infection, repair that, correct coagulopathy, and DIC, call for the senior help. Surgical operations are the uterine artery embolization in order to prevent blood loss, iliac artery ligation, and uterine balloon insertion should be there, and hysterectomy is also indicated for this condition. These are surgical options for the postpartum hemorrhage. And the another condition is uterine rupture or inversion. Uterine rupture occurs during labor that has been reported antenatally. Risk factors are the period, surgical C-section, or congenital abnormalities of the uterus, or use of oxytocin in labor, failure to recognize obstructed labor. In this way, signs and symptoms of the uterine inversion are sudden onset abdominal pain will be there, fetal parts may be easily palpable, rejection of the presenting fetal part, fetal distress, and vaginal bleeding, and a maternal shock can be signs and symptoms. Management of the uterine inversion will be: maternal resuscitation is mandatory, urgent lower segment C-section should be there, vaginal delivery if possible, then vaginal delivery should be done. And there are different stages of uterine invasion. In first stage, inverted fundus extend into the cervix. In second stage, fundus extend through the cervix but not through the vagina, and inverted fundus in third stage extend out of the vagina. And the fourth stage, the uterus is inverted. So in this way, these are the four stages. In first stage, as you can see here, the inverted part is not up to the vagina, and here it is up to the cervix, and here it is the below the vagina, and in fourth there is the complete prolapse or the inversion has been happened. So the risk factor will be full dilation, C cervix, C-section should be there, male presentation, prolonged second stage, abnormal adherence of the placenta, short cord, previous uterine inversion, and strong traction on umbilical cord can trigger this condition. So the management will be: call for help, obstetric hemorrhage protocol should be there to prevent shock, immediate replace, and push up the fundus and cervix should be done. If placenta is still attached, then uterus is left inside to minimize the bleeding, and uterine relaxation can be helpful. Hydrostatic repositioning is also important, and surgical procedures include uh, hysterectomy is the treatment of choice. So in this way, we can manage the uterine inversion. Other are the amniotic fluid embolism. Now this is amniotic fluid embolus. It is a life-threatening condition in which uh, cardiopulmonary collapse occurs, DIC occurs, and risk factors are multiple pregnancies, older maternal age, C-section, instrumental delivery, male fetus, and trauma can be cause of amniotic failure. Diagnosis will be sudden onset cardiopulmonary arrest, hypotension, respiratory distress, dyspnea, and over DIC onset duration can be there. Now, differential diagnoses are the pulmonary embolism will be there, that amniotic embolism will travel in the lungs and can create problem of the respiration. Anaphylaxis can be there, sepsis and myocardial infarction can happen. Investigations will be ABGs should be maintained, oxygen perfusion should be maintained, and uh, electrolyte should be checked, full blood count, coagulation profile, chest X-ray, and ECG should be checked for management. Management, there is no specific treatment for amniotic embolism, but patient should be admitted in ICU for high flow oxygen should be given and start cardiopulmonary resuscitation in order to relieve the patient. Hypotension, if there is hypotension, give IV crystalloids. Refractory hypotension can be there, so they should be treated by the parental inotropic agents. If coagulopathy is there, then fresh frozen plasma, cryoprecipitate, and platelets will be given. And hemodialysis, plasmapheresis, extramembrane corporeal membrane oxygenation should be given, and intra-aortic balloon pump should be given for the patients. So the this was the obstetric complication. These were the obstetric complications which we discussed. In next video, we will also discuss other types of the complications. Welcome everyone. So the topic is antepartum hemorrhage. Antepartum hemorrhage means bleeding occurs before giving birth to the baby, and that condition is known as antepartum hemorrhage. It refers to vaginal bleeding from 20th week of gestation, and a complication is about 2 to 5% of the pregnancy. Now the causes of antepartum hemorrhage are placental causes and local causes. Placental causes include placenta previa, placental abruption, and vasa previa. So we will also discuss these topics, that what is placenta previa, what is placental abruption, and what is vasa previa. Local causes include cervicitis, cervical carcinoma, vaginal infection, and trauma, and placenta previa. Okay, so the first and most important cause of antepartum hemorrhage is placenta previa. It refers to the placenta implant in lower uterine segment. Let us look at how it occurs. Now let's suppose this is uterus and this is lower uterine segment. Normal placenta is implanted here, but what happened in placenta previa? Implantation occurs here. Placental implantation occurs here, and that blocks the exit or the delivery position of the baby. That's why this condition creates problems. So that is known as placenta previa. It is associated with the maternal blood loss and a decreased incidence of advancing gestational age due to migration of the placenta, and the risk factor are the previous placenta previa, previous C-section, multiple gestation, uterine structural anomaly, and assisted conception. Now the classification will be central or total previa, and the partial or lateral previa. These are the two types of the placenta previa. Now look at the figure. This one is total placenta previa, and this is partial placenta previa. In total placenta previa, here the mouth of the opening of the cervix is totally closed, and in partial it is partially closed. So both conditions can trigger antepartum hemorrhage and can create a problem. So that thing should be done. In marginal previa, the placenta is at near but not this over the internal os. It is also known as overlying previa. Vaginal delivery is likely in this position. Marginal placenta previa is like this. It is present in the margin, and clinical features of the placenta previa are painless vaginal bleeding. This is an important demarcation differentiating point. Painless vaginal bleeding occurs, no uterine and tenderness is there. Uterus is soft and relaxed. So uterus is soft and relaxed and lying lower to the placenta on ultrasound. Fetus status initially CTG is normal. Later it is from continue to the mother hemorrhage, and then fetal compromise can be there. Management will be, first of all, we will have to manage primary survey of airway, breathe, circulation, drug, and uh, emergency exposure to the patient can be done, and then send CBC and type screen, continue fetal and mother monitoring, and trans abdominal ultrasound should be done. Stable the patient, give the patient to the blood. Rhesus negative women should be given anti-D negative and sent killer test, and unstable patient should be make stably by hemodynamically, and emergency C-section is performed. So the another cause of antepartum hemorrhage is abruption, placental separation, premature separation of the placenta in sighted placenta. Now let's suppose this is uterus and placenta is attached here in normal position, but it is detached before delivery time. That is known as placental abruption. So its complication is about 5 to 2% associated with the maternal and fetal blood loss, and risk factors are the hypertension, smoking, abdominal trauma, cocaine, and anticoagulant therapy, polyhydramnios. So these are the risk factors for the placental abruption, means premature separation of the placenta. And classification is external are revealed abruption and internal are concealed abruption. Now external revealed abruption presents with the blood which is seen, while in concealed hemorrhage there is no blood seen. In this, uterus is hard and tender. Now this is differentiating point between placental abruption and placenta previa. In this condition, uterus is hard with non-tender, and in placenta previa uterus is a tender soft, and there is uh, bleeding, but this in this condition there may be concealed hemorrhage. Now this visible bleeding is present because bleeding occurs. In concealed hemorrhage no bleeding is observed. So this is the differentiating point. Clinical features include sudden onset painful vaginal bleeding with uterus is tender, and placenta previa was painless bleeding with non-tender uterus. So the complication will be maternal complication is hypovolemic shock, Sheehan syndrome, fetal-maternal hemorrhage, maternal mortality, DIC, and acute renal failure can happen. Fetal complications include perinatal mortality and growth retarded fetus. So the management for this condition will be administer anti-D antibody, start steroid therapy, vaginal deliveries if it is possible, then go for that. If C-section is possible, then go for that for the uh, safety of the fetus. So in this way we can manage, and other management things modalities are the correct coagulopathy, packing the uterus, administer uterotonic agents, and ligate the uterine artery. So in this way we can save the life of the patient of the abruption of the placenta. And another topic is vasa previa. It is also a condition which triggers antepartum hemorrhage, and the vasa previa is a condition in which rupture of the vessels of the fetal side of the placenta occurs when membrane that contain fetal vessel connecting umbilical cord is ruptured. And risk factor are the bilobed placenta and filamentous insertion of the umbilical cord. Fetal vessels are covered by fetal membrane, and then the condition of the fetal vessels cross the placenta membrane and overlying the cervix. Presentation will be the rupture of the membrane, fresh painless vaginal bleeding with fetal compromise or bradycardia is there. So this is the differentiating point. Now there are three conditions of the antepartum hemorrhage. First one was the placental abruption, and placenta previa, and vasa previa. In placenta previa there was painless bleeding. In this there is a painful bleeding, and here in vasa previa there is also fresh painless vaginal bleeding. So these are three conditions for antepartum hemorrhage. Management will be immediate C-section with delay in delivery for fetus death is hypoxia. Now as you can see in this picture, fetal side of the vessels have been ruptured which results into the bleeding, and fetal compromise can be there.